You know, we are partnered with the TAFP, and our mission statement for the Department of Family and Community Medicine is listed there for you. And I already went through this information here. For those who are claiming CME credit, this is your code, your activity code for today. If you are claiming credits, please make sure that you do that before midnight tonight. And for those who have not yet signed up for CME credit, I would actually urge you to visit me over at the table there, and I will help you get set up with our CME office. From there, you can then follow these instructions, but it'll be easier probably if I go through that with you. But the code for those who do claim credit and have been registered is listed there again for you. And if you do claim credit, please make sure that you visit the CME office website and do check your transcript every so often to make sure that those credits are showing up. But if you have any questions or concerns about it, please be sure to reach out to me or the CME office. And also that transcript will come in handy. You'll need that in order to claim credits through the AAFP. So any questions about any of that, please feel free to reach out to me. We also want to make sure that we mention it is our goal during these grand round sessions to meet the nationally established physician core competencies that you see here. And I will let Dr. Sanchez take over with the presentation. It's evaluation and treatment of the most prevalent post-COVID conditions, rehab medicine perspective.
How's it going? I'm Dr. Sanchez. I know Dr. Gutierrez, she's on her way. She'll probably be here in 10 minutes, so she'll take over. She asked me to fill in as a backup, as a little emergency thing. Little background behind me, I'm an interventional musculoskeletal medicine specialist. I work with spinal cord injuries. Most recently started working with the long COVID clinics a couple months ago. Dr. Gutierrez taught me a little bit about managing these patients, and they're very complex patients. So I think it's interesting, as you all know, I probably encountered them in your practice, that there's a lot of stuff going on behind these patients. So hopefully we can touch base on, what the appropriate course of action and what to incorporate in their treatment plan to get them a little bit better. So here are the objectives: defining what long COVID is and its pathophysiology, which is very complex, identifying the adverse impacts of COVID-19 on patients, especially related to healthcare disparities, and so on and so forth. So here's some terminology here. What is long COVID? It's a syndrome characterized by the very persistent symptoms of health effects after the resolution of an infection. So people get infected with COVID. Usually a few months afterwards, they start developing new symptoms that have persisted for 2 to 3 months or even longer. I have some patients, that were infected back in 2020 and are still experiencing some of these symptoms. A long hauler is a COVID-19 survivor with lingering effects after resolution of their infection. So even though their COVID infections is cleared and they're no longer COVID positive, they're still having these lingering effects. And then this PASC is a actual definition from the National Institute of Health back in 2021. It's just a new syndrome for all these effects and symptoms that they're feeling even after their infection has resolved. So concept one, long COVID is a clinical diagnosis. It's a compilation of symptoms, with negative tests, things that really don't make sense, things that we really can't specifically test for. There's no biomarker, there's no specific imaging modality or anything that we can use to be like, oh yeah, you have long COVID, it's caused by this one thing, let's go ahead and treat it. It's a multi-organ multi-organ pathophysiological mechanism that's leading to a whole bunch of different symptoms that manifest differently from patient to patient. So the World Health Organization defines it as someone who has an infection and then usually within 3 months develop some type of symptom and persist for longer than 2 months. Like I said, I have patients that have had these lingering symptoms that have been going on for years that haven't improved, and in fact can worsen even with a subsequent COVID-19 infection or exacerbation of any other medical comorbidity that they may have. So the spectrum of long COVID diagnosis. So there's certain tests you can test for. If someone's having some type of orthostatic episode, you can do a tilt test or something and actually get an objective, finding and say, okay, you have orthostatic hypotension or XYZ, and something that correlates with their symptom that's identifiable. Oh,
it's hard to hear, so I don't know if you can.
Hold it a little bit closer. There you go. Okay. not too. And then there's other stuff, other tests that we can get that come back completely normal, but they're still symptomatic and still having these issues that we need to address. ME is myalgic encephalomyelitis, technically called brain fog. So people that have issues with cognitive function, memory impairment, word finding difficulty, dysautonomia. So it affects the autonomic nervous system. People that have postural orthostatic tachycardia syndrome. So they have, within 10 minutes of standing, their heart rate starts to shoot up into the 120, 150s, with really no identifiable cause. Autoimmunity, a lot of times the way I describe it to patients is that imagine if you're in perfectly good health and you get infected with COVID and it's somewhat of an acquired autoimmune state, is the way I describe it to them. And some other things on here as well. So yeah, here may respond well to interventional approaches. You have a symptom, you have identifiable pathology, you could treat that, and usually patients do well. But then when you come to this other part where there's not really something that's explaining their symptomatology or their signs, it's kind of more, it puts us in a difficult position of what do we do to treat these symptoms. Concept 2, the pathobiology of long COVID. Settled science diagnostics you need to catch up. So it's COVID is recently new within almost 4 years now. A lot of the stuff we didn't know about COVID in the beginning, the long-term effects of COVID. We're still trying to identify these as we move forward. There's a lot more cases and a lot more research putting into this long-term COVID symptomatology, and we're getting a little bit more data, but we need some more time in order to really catch up and really see what we need to do for our patients. So the pathogenesis and targets of this long COVID syndrome, it affects nearly everything. The adaptive and innate immune systems, the GI system, the circulatory system, the neurological system, any type of system, any organ system you can think of. Technically, it could have any type of effect. You have patients with, this new autoimmune issue, or they have microclotting, they're having brain fog, or they're having cardiac issues, or GI issues that are just persisting, even though the resolution of their infection. So it targets virtually every aspect of the human body. So who gets long COVID? Some research studies here, or some articles here. Oh, there's Dr. Gutierrez. Oh, she's in. You want to take over, Dr. Gutierrez? Touch briefly.
How flights work today, but okay. About who's getting long COVID. So we have more and more data that's out, but it's not good enough big data. I think we know that, patients who had really severe disease, who were hospitalized. Oh yeah. Hospitalized can have more post-acute sequela. There's other things that we don't really check in clinic, but that they check in studies, like your immunoglobulins, people with higher IgG or higher IgM3. There are also certain obesity, past medical history of diabetes, asthma. This one talked about symptoms and having certain amount of symptoms. The higher number of symptoms they had, the more likely they were to get long COVID. And then there was also certain symptoms like hair loss, was 7 times more likely if you had hair loss. These patients were to get long COVID. And then you can see these other written in the top corner. So there's a lot of patients that will have Epstein-Barr virus reactivation. So those patients will very much like get the long COVID and the syndromic long COVID and the chronic fatigue. And we already know that it can be chronic fatigue. And so it does very much in long COVID as well. Certain autoantibodies, people with connective tissue disorders, even ADHD or allergies and chronic urticaria. Just thinking they already have some mast cell dysfunction, and then now you give them the stress of having an infection, and their mast cells get a lot more angry and cause issues for these patients. And then their patients, but all the tests are normal. They may come with long COVID and they see you in your clinics, and a lot of your basic tests, your BMP, your CMP, your CBC all come back normal. And so there's no real reason, like Are they fatigued? They don't, their iron is good, their H&H is good, everything looks good on their TSH is good. But really, we probably aren't testing the right things. We don't have all the right tests to test yet for patients. We sometimes don't put enough effort to look for other things. And so when they're all normal, then does that begin, what else should we be doing for a patient that has a certain presentation next? So, if they're saying like my joints hurt, then maybe we're, I know like ANA is the bane of all existence for but I have patients end up developing rheumatological disease, autoimmune disease after having COVID and just be a trigger that caused it in these patients. And really, the patient shouldn't be proving to us that they're ill, that we have to believe them and try to do what's right for them. And we have to understand that post acute infection syndrome, this is not the first one. There's been long flu, there's been Lyme, as difficult as that is as well. Post-treatment Lyme is a thing. Post-viral dysautonomia dysautonomia is 50% of the time is caused by an infection. It doesn't always have to be COVID. It really often now is COVID. And so these patients, this has been underfunded for a really long time. And the other thing is we do not have a diagnostic biomarker. And so that really makes it hard for us to say like, oh, like, let me just do this one test and it's going to tell me that you have long COVID. And so there's actually now studies that are about to come out, hopefully, that they showed kind of the big biomarker maybe that is being shown in some patients is having microclots and hyperactivated platelets, but we don't have a way to check that in our normal lab, day-to-day labs either. I can't even so I could get into the pathology department. Can we do this? Well, we don't have that special scope. So no one's even willing to do it for my patients or for research purposes, but it's been found. And so they found some other abnormalities. We'll talk about them. There's some with immune response in some patients, they have more low cortisol and almost there are people who have symptoms and they say I have these symptoms of long COVID went perfectly with the biomarkers that are being done in research. So for the most part, we can believe the patients when they say it and we can make the diagnosis that way. And so really right now what we have is listening to our patients and, I feel like y'all do it the best. So what does recovery look like? And, outcomes can be different just depending, again, right now, it isn't as severe as it used to be. So not as many patients, thankfully, are dying. Some patients we're still having some patients be hospitalized. Patients are still having even silent COVID or asymptomatic COVID. And we're still learning the numbers on what percentage will have ongoing symptoms, 10 to 50% probably. The other thing we don't know is what's going to happen for post-COVID. So I take care of patients who have MS. We now know that MS happens from history of EBV, with that being the biggest risk factor. I take care of patients who are post-polio. We know that post-polio happens decades, 5-6 decades later after patients have polio. And so what's going to happen 5 or 6 decades after this? There's been studies showing that other infectious diseases cause dementia and put patients at risk for dementia. So there's another study that came out today for UT Health Houston saying that even like getting COVID infection changed our genes. So I was like, great. Just what we need. So numbers are saying like, okay, 1 in 5 had long COVID. They did the household pulse survey that they've been looking at throughout the whole pandemic. And in the summer, they started adding something that were related to long COVID symptoms. And we're finding it was about 20% of the patients who are having long COVID. And the National Center for Health Statistics continues to follow this. So this is followed through different variants. And so you can still see it's about national estimates in the US, about 15%. This was the March data, so earlier this month. And then by age. So if you look by age, it's a bell curve. And it isn't the older people getting it, but it's actually that 40, 50-year-old. And if you look by sex, females more than males, race and Hispanic ethnicity, every time this has come out, Hispanic ethnicity has been at the top of the list. And this is what we see here in our town. Again, kind of education doesn't matter. Also, college and associate's degrees have it, and then patients with disability status previously also are at higher risk. So what about in children? It happens in children as well. The numbers probably overestimated early on, but anywhere from 0.5 to 2% of children could develop PASC as well. And so they think that maybe older adolescents are more at risk than younger adolescents, but I have friends that in different parts of the country that specifically are only pediatric related on COVID, and they are seeing it in very young children who sometimes can't explain some of their symptoms or having weird neuropathic symptoms. The kids, this is also from the CDC, you know, they're getting more pulmonary embolisms, more myocarditis, cardiomyopathy, BPE, renal failure. We know we've seen here a lot of type 1 diabetes and type 2 diabetes that's happening for kids and adults as well. And so really it's still the, you know, take home message that it isn't, that it can happen in kids, even though the numbers are really small. When patients are hospitalized, you know, I wrote this with colleagues of mine from 11 other countries at the beginning of the pandemic, and we just said, look, patients are going to be hospitalized. They need to get some kind of rehab, because we know even before for AMDS and critical illness, patients benefit from rehab. And we also had another paper, like, what do we expect to see? And this is what we expect to see based on other pandemics that were obviously smaller. And this is very much what we saw in hospitalized patients. And when patients, I won't focus too much on the hospital part, because then you're mostly seeing them at the hospital. So I'll kind of focus more on that. But just, you know, when they're in the hospital, I want them to start early mobility programs. So, at our hospital, we're consulted on the team, and we get rehab involved very early, including, you know, walking them around when they're still on the vent. The other thing I always like to talk about is healthcare disparities, and University of Colorado looked at all their patients who had done PT and OT services for acute COVID-19, and the ones who were least likely to get it were the ones who were Hispanic ethnicity, and specifically ones who spoke Spanish. So it was kind of a nice, like, eye opener for their system to say, like, what is the unconscious bias that we have with patients who are Hispanic or Spanish speaking? Just more data saying, you know, inpatient rehab help for patients who were hospitalized with severe COVID-19, and when patients are inpatient, that it does matter. Like when they sent patients to inpatient rehab or skilled nursing, but the ones who went to inpatient rehab, they actually were sicker, were in the hospital longer, had more ICU days. And those are the ones who went to inpatient rehab, and they were also less likely when they went to inpatient rehab to transfer out to the acute care hospital, even though they were sicker and had been in the ICU for longer days. So I guess that's not even our doctor, but go to inpatient rehab for your patients. And then this was a study where they looked at outpatient rehab services. So again, not everyone is inpatient or needs inpatient services, but in outpatient, a lot of times your patients can benefit from outpatient PT or OT, and they looked at this big data. And Black survivors of COVID were less likely to get outpatient rehab when they looked at big data. Actually, in this case, Hispanic patients were more likely. And then also when they looked at symptoms, then Hispanic patients were most likely to have fatigue. So what are the long haul symptoms that we're seeing, or that you're seeing also? This was probably one of the first surveys that were done when they looked at 50 most common symptoms. You see the top one there. The number one is fatigue, and then muscle body ache, shortness of breath, anxiety, headache, dizziness. 25%, so 26%, so almost a quarter of the symptoms are something related to pain. So again, things that you see that show up in your clinic, that show up in your, you know, primary care office and PM&R offices, because these patients are having consistent body ache, headache, hip pains and joints. This is big data showing just, you know, looking at big EHR data to say, like, what happened when you look at medical records and patients had testing done, and when their test was negative versus their test was positive, and then they follow afterwards the EHR to see, did they develop new symptoms? Did they have new diagnoses for ones that were positive versus ones who weren't? And then the answer was yes, there was. It was about 11% of patients who were having new symptoms and new diagnoses, both if they were older than 20 and younger than 20. Again, so going into that PEDS group, they said, oh, it was infrequent. It was 11% prevalence, but I think 11% of 100 million people that have had COVID is a lot of big numbers. So, you know, these are a lot of patients that we're talking about. When I talked to some of my other, I was working with the Departamento de Salud of Puerto Rico about looking at their own data and surveillance that they're doing there. Their percentages are probably closer to 40%. And I was talking to friends of mine that are physicians there, and they said, oh, no, we're not seeing it. And I said, are you asking? I think this should be part of a past medical history now. Like, did you have COVID? How many COVID infections did you have? What were your symptoms in relation to having COVID-19? Because it's, you know, it's pathobiological. In this study, they started seeing that actually the big thing in this one was these were patients who were mostly 45-year-old females seen at a, you know, a clinic. And they had, in half of the cases, had a symptom-free interval. So they had COVID, they had gotten better for about 25 days, and then they had new symptoms that came on later. So that's another big thing that you'll see. And for a lot of those patients, there are new symptoms that they didn't have before. So you can see on the left, they're like fevers, chills, anosmia. And then, you know, when they had the symptoms occur, they were in multiple different areas, and greater than 25% had new neurologic symptoms. For my own disclosure, I had COVID, and then what was the most mild COVID you could ever imagine. It was sniffles. I just actually took a test because since I'm a runner, I had to run that morning. That was really bad. And then my average resting heart rate was up. And so I was like, well, that's not normal for me. So I just had a running nose. So I took a COVID test and it was positive. And then it was just more of an annoyance because I was like, oh, you know, and it happened over my week of vacation. So also not great. Then I was fine until about 2 weeks later after a run. And I just broke out in hives and was super fatigued and just was like on the couch for the rest of the day. And it wasn't a hard run or a long run, type of thing. And that was the beginning of what my long COVID was. Systematic review showing again most common symptoms: fatigue, headache, attention disorder, hair loss, dyspnea. And sometimes the attention disorder is what the patients mostly have. You'll see a lot of a little forgetfulness that sometimes is related to attention. And then the other thing you'll hear a lot is anomia, or they won't say I have anomia, but they're saying like, I can't find my words, or I don't know what I'm supposed to, you know, I can't come out with the words that I want to come out with. And that's a little bit of, sometimes falls under the attention disorder, but we, you know, hear that, that's very much a long COVID thing. I even heard there was a surgeon who was in the OR and he couldn't like know what the tools were called. He couldn't tell the surgical tech when he wanted to grab which one. I mean, I can't tell you what it's on because I'm not a surgeon, I don't know, but he should know. And they were like getting mad at him because he was trying to grab for it because he couldn't say what it was. So, you know, it's very impactful to people's work. Then again, it impacts multiple organs. There's immune dysregulation, there's exhausted T cells. You know, you can test for, you know, some patients will have reduced, some of them have reduced CD4, reduced CD8 counts. I have patients who, you know, they have some leukopenia, when, you know, you can sometimes look in that and they'll have a lower white count. Ones with very low CD4 and CD8, some of them get very frequent infections after that. They all have increase in non-classical monocytes. There's a lot of, I almost say it's more of a vascular disease. It's definitely not just pulmonary, but it's vascular because it can get everywhere. There's endothelial dysfunction, circulatory system disruption, neuroinflammation. The patient-led research collaborative, they've been great about leading research. Their patients that are leading it, that were doing science and AI and research beforehand and got long COVID, so they really cared about this. And they also did an international web-based survey, and they kind of the main things that they were showing is that if you had symptoms more than 3 months or more symptoms, it was gonna last longer and be something that lasts longer than 3 months. So again, kind of figuring out at the beginning, how many symptoms they have, it's probably gonna be something that's more longer lasting. And that there was relapses and there was a lot of exacerbations by exercise and stress. In this long COVID cohort study, so this was almost 1,000 patients who were symptomatic at 2 months. And then they looked at a year out, and at a year out, there was still 85% who are having symptoms. And then they showed symptoms like these symptoms got better, these stayed the same, and these became worse. And this is the list of the ones that got worse. So the ones that got worse is neck, back, and low back pain. And that's such a nondescript, you know, you have so many patients come in with that, but you know, we see that also a lot in our PMR clinics. And so if someone had COVID and long COVID, they may continue to get some of this pain, paresthesias, ear pain, again, a lot of things related that you are going to see, bone and joint pain, hair loss, blurry vision, discoloration and swelling of the hands and feet, like I talked about, vascular dysfunction, heaviness of the feet, and again, relapsing, remitting. So if you were like sleeping or eating, this slide is probably one of the most important ones that I like, because this is what you see, and sometimes you wonder like, oh my gosh, what's going on? This patient has a million different things. They're dizzy, they're brain fog, they're you know, their blood pressures up and down, they're having tachycardia, they're having, you know, instability in different things, swelling, nausea, sinusitis, but really, all of these really what seems to be disparate symptoms really are interconnected when you think about the disrupted immunity and the inflammation and the nervous system dysfunction. And it really is going to take a holistic approach to take care of them, since we don't have all the like magic tools or treatments, but really it, we have to help patients understand what the impact is and how we need to look at it holistically. It's like, I don't have a magic anti-inflammation pill. And so again, this is a nice little picture that came out in the brain where it's like, okay, some patients have exercise intolerance. And I'm like, what is exercise intolerance? Because that's part of my long COVID. And so it's like, I can't exercise like I used to at all. And I was a very, like an elite level master's athlete. So for an older person it was a good, and now it's like hard to, I can't be as fast as I was or run as long as I could. So that's, you know, and that sometimes seems like nothing for people, like, okay, well, you can only run 6 miles. That's great, right? But I used to run 26 miles. So I even have had downplaying my symptoms because it still seems like I could do a lot of stuff. Cognitive mood and sleep disorders, the pain syndrome, and the dysautonomia, which we're going to talk about because there is so much dysautonomia in long COVID, and it's probably something that we didn't get very much of in our medical schools. So really, this is, you know, you listen to the timeline of the events. You don't need lab tests. It's a clinical diagnosis, and it's, you know, really the CDC and World Health Organization, they encourage a clinical diagnosis, not based on lab values. And we, again, knowing this is pathobiological that can cause the symptoms. And so what is the next concept? Is that we're going to objectively measure what we can measure, what is seen to be subjectively reported to you. So these are, you know, when possible, I have these ready or I print them out. So I'll use the fatigue severity scale. We know that that is something that is validated in Parkinson's, in MS, and all, in traumatic brain injury. So we know in sleep apnea. So we know this is something that is a validated measure. It's now actually validated in post-COVID as well. Sometimes I'll give them quality of life scales. The Compass 31 is one for autonomic dysfunction. So that's a good one to give patients who have autonomic dysfunction. The DePaul symptom questionnaire and the short form, that's one for ME/CFS, myalgic encephalomyelitis or chronic fatigue syndrome. And so sometimes I will be like, take these home with you, send them back to my office. I don't always have time to like sit with someone as they are filling these out. But it's nice to have these validated measures, because especially if the patient may need a if you want to follow it over time, or if they're going to qualify for disability, which some of them will need to have disability, then having these validated measures is sometimes the difference between them getting services or getting disability versus not. In this study, they looked at this was a preprint, but this is hopefully coming out soon. And so they said like structural pathology was not correlating. So again, we can do the test and you can get, my echo is fine and my, I don't know, no one did a chest X-ray, but I think it's fine. But my echo is fine. And, but that doesn't mean I don't have long COVID symptoms. And so in this study, two major things, and it wasn't everyone, but there was a tendency for low cortisol in patients. And what's interesting is then, like for these patients, if you stim test them, it's normal. So it's not something like adrenal, but something maybe still in the HPA axis that is, super adrenal. So I don't know. And then the other, so in that, the big purple one is kind of where the low cortisol fell for the patients who had long COVID. And the other thing that they found in about 20 to 30% of the patients was very high levels of exhausted T cells, which is the CD 14 and 16, which can be checked, but so in some, their immune system is reacting to something in their body and overreacting to something that's in their system. There's been studies with showing viral antigen persistence in different tissues, whether that be, the GI tract or fat, or they found it in pregnant women, pregnant persons who got COVID when they were pregnant, and then months later, their babies are born and their baby's poop has, COVID antigen in it. So, there's still, that's why one of the main trials that the NIH is going to do for long COVID is going to be PASC trial because of, what they think is viral resistance. Please still look for ovarian organ pathology in these patients. I'm not saying that everyone's going to have a normal test, but not everyone's going to have normal tests. So if they come in and they have shortness of breath, still they'll need PFTs and lung imaging. If they have palpitations and chest pain, then please still get EKGs and echoes, because you still have in a small percentage of patients, people who will have, will have a myopathy. And I had a myocarditis patient, it's a very, who, otherwise, was having palpitations, and you would just think like, oh, some patients have palpitations. No, he had myocarditis and pericarditis. And if they have some kind of severe neurologic impairment, then yes, they need brain imaging. So still don't forget to do that. So maybe some patients. And so, people's course are different. You heard about 200 plus symptoms. They want to be heard. They want to be validated. They want to be offered some kind of, even if it's symptom management and validation. And so we knew at the beginning of the pandemic that a lot of patients were, that underserved patients or minoritized patients were Black and Hispanic were hospitalized more. And we knew already these patients who don't usually get rehab services are from those same groups. And so I opened a post-COVID clinic in July of 2020 to be able to, reach patients here in our city of San Antonio. And we've seen a lot of patients since. But we can't do it alone. So that's why I'm here talking to groups like yourselves, and we see everything from my tongue is a little bit different to I had an oxic brain injury and I have 4 limb spasticity that needs interventional management with botulinum neurotoxins and intrathecal baclofen pumps, which is my specialty also, to 4 limb amputations, and then the exercise intolerances and such. So this is like our initial data, mostly females, 65% females. At the beginning, this was in the first 4 months or 5 months, and about only 25% were hospitalized. It's definitely less now. Most of the patients we see now by far are not hospitalized at all. The age range, actually, if you look in close, the highest one is 40s. So again, 40s. And what we were seeing was about 59% Hispanic patients. So it kind of very much mirrors what we have here in San Antonio. These patients were referred to therapy. So A lot of times the therapy is very different than the traditional therapy, because a lot of the therapy is really, and I have to work with different therapy partners and sometimes educate them, because it's not like, oh, I'll just get on the exercise program and go hard, because actually patients have a lot of post-exertional malaise or post-exertional symptom exacerbation. And if you give them the regular kind of physical therapy themselves, they will crash or have more symptoms or just feel worse with all their symptoms. So really some of the exercises start with breathing and literally like doing deep breathing exercises. And that also helps with their autonomic nervous system. And we sent some patients to behavioral health. Some of our data that we showed there's a really high number of patients that had PTSD, especially from early in the pandemic, where they were just like thought they were going to die, but they weren't sick enough to be in the hospital. And so there was a lot of trauma related to that. And not that their PTSD is causing their symptoms, but they're just traumatized by their symptoms, and then they don't know what's going on. And, you know, it's a lot of medical trauma. We looked at, this was a bigger look of probably at least the first year and a half of our clinic. And this was like, okay, does the date of infection of our long COVID patients match with the waves? And so if you look at this one, the first one is the CDC wave, and the second one's the Bexar County Metro Health data. And then the third one is our own, the blue one is our own. So very much looks like, you know, when the waves happen, that's when patients get infected, and that's when patients get long COVID. We looked at things like returning to work and association with long COVID symptoms. We didn't find anything. And that's probably because some people force themselves to work even when they probably shouldn't be working. They just kind of have to, and it really depends on their situation. We looked at, you know, higher symptom burden scales, and usually females had those higher scales. We looked at mood data, and a lot of times a higher score also went with a higher GAD, which was for anxiety, and for the PTSD. A lot of them had insomnia, especially if they had, you know, depression or reduced quality of life. So things that, you know, kind of made sense, but also worked with our data too. And a lot of them, like I said, have stigma. They have studies showing there's a lot of stigma related to this. Yes. So the later variants of ours, we haven't like put it all through yet to look, but there's still patients coming with Omicron all the time, similar type of symptoms. So cardiovascular manifestations, again, if they have the symptoms, screen for it, look for it. I work with my cardiology partners. When patients want to know when can they get back to activity, and really I still am like, okay, take your time. It's like a concussion protocol. It's literally like a concussion protocol where patients, you know, don't push it too much when you get sick. Wait till all your symptoms go away, and then you can start going back to activity if you were more symptomatic or have symptoms, and get a workup. Athletes can get long COVID too, and they looked at NCAA athletes and tracked them very, very closely, and these are the healthiest people in the, you know, the US, I think, you know, I believe, and still 4% were having exertional symptoms, and, you know, 1.2% were having persistent symptoms, and those with exertional symptoms, they got workups and they had abnormalities and abnormal cardiac MRIs, or had dysautonomia or pneumonia or inappropriate sinus tachycardia or POTS. So again, even happening in the healthiest of people, you see it all the time. Even like Messi, they said he had some hard time coming back from COVID, and that when he would play, it would make him worse. So even he was having some post-exertional symptoms. Obviously he did well, because, you know, then he won it all. But so what about this, like, if I don't have cardiopulmonary disease, why can't I exercise? And they've done, now there's more tests on CPET testing. That's probably what I'm going to have to push my doctor to order next for myself too. And so that's an ability to see, like, is it cardiac? Is it pulmonary? Is it just stability? And so for these patients, they actually had a reduction in peak oxygen consumption peripherally rather than cardiac. So their heart was working fine. It was more about, you know, the oxygen peripherally, like their muscles were not uptaking oxygen correctly, and that dropped their VO2. And they also had exaggerated hyperventilatory response. And so this was another CPET study that they did. These were patients that had normal PFTs, chest X-ray, CT chest, but still had this unexplained dyspnea. And of all of those, only 2 had completely normal CPETs. So, you know, this is something to think about. Patients are still having symptoms. They're having a lot of really high respiratory rate, dysfunctional breathing, almost half met criteria for MECFS. And again, the same issues with their peak VO2 was less. And then this is like looking at a systematic review of all the kind of exercise testing, and that's me feeling really bad at the end of the marathon. Not recently, this was like a couple of years ago. And that's how these patients feel, but it was almost the equivalent of them losing 10 years of their exercise capacity. I've been referring some of my patients for EECP. This was something that they used traditionally for cardiac or for angina, unstable angina. And so it is like they put big pressure, like almost cuffs on your legs and 3 leads of EKG. And each time the heart's in diastole, it squeezes. So it's almost like it's literally doing fake exercise for you, and it increases nitrous oxide, and it helps increase vascularity, and it increases cardiac output. That's why it's helpful for persons who have endothelial dysfunction and angina. And so we thought that it would probably also help patients who have long COVID. And so this is just, yes, we're looking at it. It's not randomized blind trial because these are just patients who are able to get it, but have, you know, decreased fatigue scores, angina scores, increased 6-minute walk tests, and even now increased in cognitive tests. And they use this, they're studying in MECFS. There was just a study that said they even use it in patients now who have dementia, who just, you know, think it's great to get more, you know, oxygen and better vascularity to your brain. So this is something that insurances are covering for long COVID, at least in Blue Cross and in United Healthcare. So I can get my patients, and a lot of patients have Blue Cross in town. So I've been able to send a lot of my patients to get EDCP. I'm doing it myself right now, so we'll see. I've only done 6. And there's a lot of neurologic sequelae. There's been, you know, abnormal CSF in patients that they found, especially ones with cognitive sequelae. For these patients, some of them, if it's I will send them for neuropsyche. I'll send them for speech therapy. It's a nice, easy step given techniques. And then I will use medications like I use in the brain injury and stroke population, or in patients who have, you know, mild cognitive impairment. And some of those medications are helping patients as well. There's done PET scans in patients showing hypometabolism in patients with long COVID, so they're not getting, you know, there's increased metabolism in their brain, and then there's other studies that showing decreased cerebral blood flow. This was a study where in a brain bank, and in the brain bank, they had reduction in primary olfactory cortex and also in the perihippocampal gyrus, which of course is the memory place, reduction in global brain size of 0.2 to 2%. So again, the equivalent of 10 years of aging in these patients. They get, again, they had pre-scans and then they had post-scans in ones who had COVID. So I don't want 2%. This was a study from the VA system, and so they looked at neurologic symptoms. And there are patients who had COVID. They can, you know, they get this big data on their system, and in over a year, those patients that had COVID had a 42% increase in any neurological sequelae. And these were even for non-hospitalized patients. So lots of, like I've talked about, these patients are going to have cerebral blood flow dysregulation, hypocapnic hyperventilation, small fiber neuropathies, dysautonomia. So we're going to talk about PASC, postural orthostatic tachycardic syndrome. This is someone that often comes into your clinic and they just feel like their heart rate sometimes goes up, or they feel like they have palpitations, and you know, their echo and those types of things are usually fine. The best way to diagnose it is with a stand test. I can even do this on my telemedicine visits because everyone has those little things to measure their pulse and their heart rate at home, and I could have them, they could be sitting and then they can sit and they're like, my heart rate's 75, and then I have them up, and it's supposed to be a 10-minute stand test, but sometimes even within 3 minutes, their heart rate will be 130, and that's how you diagnose POTS. I know you don't have to have a a head up tilt test, which yes is the more official one, but sometimes you even see it in just doing orthostatic. So sometimes it's, I'm seeing these patients in clinic, and it's like, can I take 10 more minutes to do this? And sometimes 10 minutes is a lot, but you can either like get your nurse to do it, or sometimes I send patients home with a paper, they do it at home and check their vitals, and then send it back to us, and I can diagnose it that way as well. And so it's the data that we have from our own patients that have POTS. It took probably almost 300 days for someone to get the diagnosis from when they initially had COVID, because a lot of times they were just like blown off or told their heart was fine, or they had an EKG and an echo and their echo was okay. And it wasn't until we did a stand test. Very few needed tilt table tests actually. Did they get this diagnosis? A lot of them told they were just anxious or it was just anxiety. And so for them, it's a really like fluids, salt in their food's okay if they can tolerate it. And a lot of times their blood pressure isn't really high. You compression garments, so do like compression leggings, abdominal binders, both of those. Therapy, getting them back into therapy to work on an autonomic reconditioning program. They do have POTS protocols, Levine protocol, Dallas protocol that we used for patients with POTS before even COVID, and avoiding exacerbating factors like if it gets too hot, or that sometimes exacerbating factor, a big meal, because all their blood flow goes to their stomach. And so it's neurocardiologic, and it's not just tachycardia, but really I say it's preload failure, because your venous system's not responding correctly. So you're not getting blood to anything that's above your heart. So these patients sometimes the brain fog's actually more when they're sitting up, and then when they're upright, and when they're lying down. I have some patients that can work from home, but like, so they have to work laying down, and that way they, can be able to work. And that's, so yeah, headaches, they have that coat hanger pain. So we have the coat hanger pain, if you hear that coat hanger pain, and it's often because these patients, like your cervical extensors have to be firing all day to keep your big heads up. And so that gets less blood flow and they get pain there. Again, just so much neurologic and psychiatric data. I know we don't have much more time, but the neurologic and cognitive impacts persisted for the 2 years, but then the psychiatric ones did not. So sometimes, yes, there's also been an increase in psychiatric issues happen after COVID, but those usually calm down. And what's happening probably related to, inflammation, decrease in neurotransmitter, increase in, NMDA and other types of excitotoxic cells that are causing cytokine storm in our brains. So the post-viral fatigue, a lot of the patients actually, believe it or not, if you start asking, meet the criteria for PSS. The big thing with that is knowing about post-exertional malaise, which is kind of that patients, maybe they can do something, but then afterward, that should be otherwise simple, but otherwise that easy thing causes a crash or causes symptoms to get worse, or they get fatigued. And sometimes the fatigue can happen a day later and it can keep them in bed for days. And so along with that, for them to, and a lot of patients don't know they meet these criteria for ME/CFS, but so it's really like, they have to have this reduction in, an impairment in activities that they would do, have post-exertional malaise, and have unrefreshing sleep. And then at least one of the other two, which is cognitive impairment or the orthostatic intolerance. So sometimes this goes with different as well. Next concept, treat comprehensively using interdisciplinary principles. I'm an author. We have 7, almost 8, should be coming out any day now. Guidance statements that are multidisciplinary, collaborative, consensus guidance statements. We have a large one for our National Academy and its multiple specialties coming in and who have long COVID clinics and talk about, how do we assess, what labs should be done. Hopefully our next paper will be kind of putting it all together in one like easy to carry thing. So it's not like 7 different papers or 8 different papers. The fatigue thing, I'll tell people the 4 Ps, pacing. So really they have to pace themselves. Some people, they just want to go. Remember, these are 40-year-olds who otherwise are moms, working moms, people doing things, physicians, and it's really hard to get some people to pace themselves. And that's probably one of the best things that helps with their fatigue so that they don't go into crashes. Same thing with prioritizing, like what activities do you have to do and, make sure they just do that. Positioning themselves. Sometimes I'm like, get a shower chair. I had one patient that said like, what helped me so much? And I was waiting to hear some like miracle cure that I was gonna like tell everyone about. And it was a rollator that she could like stop and take a breath, take a break and sit in her rollator if she needed to take a break. And that made the difference between her like being able to go back to work in person or not. Or sometimes I'll get them a shower chair so they can sit in the shower and not waste their energy in the shower. And then planning things in advance. So this is, what do we have? What do we know? We know how to take care of headache and migraine, take care of like what you see in clinic. But listen to like migraine is a huge thing. Headache's a huge thing. It has to do with the inflammation. I went into migraine status after my own. And so just treat those as you know how to treat them. Treat pain symptoms, treat the POTS, cognitive dysfunction, smell, taste, and then the rehab strategies are with the guidance statements. There's therapy programs, there's, therapists can look at this website to help guide them. The long COVID outpatient rehabilitation, breathing exercises help increase vagal tone. So it's going to help some of these patients that have autonomic dysfunction. And, they can even order these little breather things online or incentive barometers, and even starting with breathing is going to improve their hyperventilation and the hypocapnia that comes from that. And so very helpful. The World Health Organization has a living guideline on management of rehab, and it's kind of everything that I've told you today. Make it multidisciplinary, look for red flags, work up those red flags if they have those symptoms, look for post-exertional symptom exacerbation. Like I said, some of them do poorly in traditional rehab and have to really do the slow pace type of program. And then, get them, teach them what triggers are. So, they can be exacerbated by physical or cognitive exertion, stress, dehydration, weather changes. I know that sounds weird, but I feel, my husband thinks like, what? And I was like, if something's coming in, I feel a little bit worse, but they have even an app, it's called Weatherwell, and you can know when there's gonna be changes in the weather around where you live. Alcohol, was horrendous for me at the beginning of my like. It was just, I was like, oh, maybe because it was red wine, I feel bad. White wine. Okay, maybe, all right, it's all wine, never mind. Alcohol, very, very full. And then also, persons that menstruate, premenstrual time can be very bad for symptoms. So what do we know about treatments? And it's really right now, things are just being studied, and it's not being studied as quickly as everything else, but there's some thoughts that I didn't put it aside, but probably like, what do we know can help prevent long COVID or decrease long COVID? So one of those things is don't get COVID. There's probably like 10 to 15% of the population who've never had it at this point, and it's probably like that number is shrinking as the days go on. I think we need a study like who's not getting it? Do they have some like amazing natural killer cells or something? I don't know. The next thing is vaccine. Vaccine still can prevent. People who are vaccinated can still get long COVID, but it still is a decrease, some more than nothing. The other one is actually there's studies now Paxlovid. So ones who got Paxlovid, a study just came out in JAMA Internal Medicine. Again, VA data looking at Paxlovid and showing it decreasing long COVID in 46%. So I'm a big fan of COVID. I know it has a lot of interactions, but I lean towards. I mean, I don't often see patients acutely, but some of my patients re-get COVID, and so I'm kind of a fan of giving them Paxlovid, especially since we're gonna trial it in long COVID anyways. And then the other one is metformin. And there, it's actually a preprint, so hopefully gonna be published, but they had looked at it first as an acute treatment. It didn't really help too much in the acute setting, but then when they looked at it over 6 months' time, then the metformin decreased by 23% in patients who had long COVID. It was only a 2-week course of metformin around the time that they had COVID. So, you know, another consideration, probably a lot of patients could stand to be on some metformin anyway, so, I mean, I probably could stand to be on some. All right, so, and then the other things were just, you know, there's dysbiosis. So would a patient benefit from like probiotics or prebiotics? They need to look at that. There's, if patients have immune dysfunction, IVIG, if they have, again, they're doing studies on the abnormal clotting and looking at the microclots. And they're doing triple therapy, which is a little kind of scary because clopidogrel, aspirin, and apixaban together, you know, even makes a cardiologist or neurologist shudder. But those are some of the things that they're looking at right now. Inflammation, antihistamines, a lot of people, you'll see their allergies go haywire. So I'll put patients on kind of a mast cell protocol where I'm just giving them, you know, H1 blocker, H2 blocker, non-sedating ones, and, you know, keeping them away from triggers. That sometimes really helps patients with some of their symptoms, especially if they have anything kind of allergic, asthmatic, GI type symptoms or rashes. I had, again, a lot of rashes. Was one of my first presentations, so I even put myself on one of those types of protocols. Low dose naltrexone. So what we know about that is this is different than regular naltrexone, which is kind of like anti-abuse opioid type of thing, but low dose naltrexone specifically is a little bit more immunomodulatory and anti-inflammatory. It's working on toll-like receptor 4s. And so they have studies in it in ME/CFS, in neurologic conditions like Parkinson's, fibromyalgia, cancer, CRPS patients. And now there's studies in PASC. And I think probably the things that help my patients the most is doing the flow therapy, the ECP, and low dose naltrexone. This one is, it's low dose. It's like you start at 1.5 and then I'll go up maybe to 3 or to 4.5. Remember, regular naltrexone's 50. And so usually it's compounded for them, not expensive. And in this study, it was helpful in chest pain, tightness, cough, joint pain, low mood, personality changes. So, you know, some patients it helps with their energy, some with any kind of pain type symptoms. And it's definitely better than me. You know, I'm not someone that's going to be putting someone on opioids for their pain, but this is something that has helped tremendously with a lot of patients. And again, helping with the immune system, helping with inflammation. You need to support them for disability and provide work accommodations. This is sometimes, again, a super important thing that we do is just make it like, give them time to recover, know that there's relapses. I fill out lots of FMLA forms, giving people time to, you know, saying they may need some days off if they have a crash. Or when they go back to work, that it's a graduated return to work program. The worst thing I can do is they go full time and they crash, but the best thing is if I give them like, okay, let's start with 20 hours a week and do that for a couple weeks and then go to 30 hours a week and then go to full time. And those are the ones who are able to adjust and do well. And these are, you know, like I said, get them breaks. I have them avoid standing. Sometimes I give them preferential parking. I will also sometimes give patients like handicap placards for a short term, just so that they don't use all their energy to walk into work. And then that's all the energy that they have. And, or tell them like, limit their work or limit their work with divided attention or go early if they need to. It is a disability under the ADA. So that means that they can have these accommodations, but it doesn't mean that they're automatically going to get disability. You know, it's not yet an impairment with Social Security. We're actually working on that. The other thing you can do is send patients. We're still recruiting patients for the Recover trial. So we get patients enrolled in trials. So we're trying to learn first what's going on more, and then we'll be treating these patients with treatment trials. And then use your community for things, you know, I was like, try to see them early, you're gonna see them early, you know, validate what they're gonna see. If they need inpatient, then, you know, they get inpatient, if not, then, you know, home-based rehab, like sometimes I'll use Rehab Without Walls. And they know how to take care of long COVID patients, they start with the breathing and the brain fog and know about autonomic reconditioning and make sure that they have mental health services. And so now, and then lots of references. Questions or comments? Who's like, yeah, let's say, yes. So, okay, so there's two post-COVID